Hi, my name is Andrew Yee, and I'm at the Center for Multiple Myeloma at Massachusetts General Hospital Cancer Center in Boston, Massachusetts. Thanks for giving me the opportunity to talk about our presentation that will be at the plenary session. And this is so the study I'm presenting on behalf of our investigators is a Alliance Foundation trial looking at a 4-drug combination of daratumumab, lenalidomide, Ixazomib, and dexamethasone in transplant-ineligible deferred patients. So why is this study important? We know that for newly diagnosed patients, regardless of transplant eligibility status, a 4-drug regimen is now a standard therapy. So again, the 4 drugs of an anti-CD38 monoclonal antibody, lenalidomide, proteasome inhibitor, and dexamethasone are a standard regimen. Now, we all recognize that for older transplant-ineligible patients, we have to adapt these regimens to make it user-friendly. And for the randomized studies that have been presented, the ones that we've all heard about, they essentially took the same regimen for a younger patient population and are using it for an older patient population. But can we do better? Can we make it more user-friendly? Because we know that older patients may have more side effects from therapies compared to younger patients. So the Alliance study took the same principles of a 4-drug regimen and also took some of the learning we have developed from our own experience, for example, with RVD Lite, where we reduced the dose of lenalidomide and spaced out the proteasome inhibitor to help improve patient tolerability. So we took that principle and applied it to a 4-drug regimen, and we have daratumumab, lenalidomide, Ixazomib, and dexamethasone. Now, in the study, we reduced the dose of lenalidomide from 25 to 15 milligrams, and we replaced the proteasome inhibitor bortezomib with Ixazomib. So Ixazomib is an oral proteasome inhibitor. And what are the key differences between using Ixazomib and bortezomib? Number one, it's an oral drug. So already it's more convenient for patients. You don't have to go in the clinic to get Ixazomib. You can take this drug out in your home. And number two, we all know that bortezomib can be associated with risk of peripheral neuropathy, which can be a side effect. For some patients, it's not a big deal, but for some patients, it's a big deal. And the nice thing about this oral proteasome inhibitor is that it's not associated with peripheral neuropathy. So the fact that it's an oral drug and lack of peripheral neuropathy, it lends itself to being a drug that you can take for extended periods of time. And so I think it's an important tool we have for myeloma patients. So our study explored, again, this 4-drug combination. And the key takeaway, and based on the interim results of this study that are being presented, we looked at the first 12 cycles of therapy, is that the outcomes of these patients after the 12 months in terms of the progression-free survival of it's north of 90%, and it's very comparable to what has already been published using a higher dose of len and with bortezomib. You can get the same thing with a lower dose of lenalidomide and an oral proteasome inhibitor. And then number two is that we found that the rate of peripheral neuropathy was significantly better than these other studies. But there's no grade 3 neuropathy. When people talk about neuropathy, grade 3 neuropathy usually is a type of neuropathy where you might have to be hospitalized or maybe in a wheelchair, for example. We have none of that. Whereas in the other studies, it's around 3 to 5%. So that's a key advantage. Second advantage is that the rate of neutropenia, grade 3 neutropenia, was much lower. In the previous studies we've heard about, which are the kind of key mark foundational studies, the neutropenia rate of grade 3 or high, which is neutrophil count below 1,000, in our study was around 15%. Compared to the other studies, it's 50%. So again, I think all these things, I think our goal here is to kind of come up with a regimen that has efficacy and is also more user-friendly and is also thinking about the patient in front of us, the older transplant, how can we adapt a 4-drug regimen to make it more user-friendly and also maintaining efficacy. So at this meeting, we're presenting the interim results. I think we're waiting longer-term follow-up to know what is the contribution of doing daratumumab, lenalidomide, Ixazomib as extended therapy versus lenalidomide as maintenance. So stay tuned. We'll have results of that forthcoming, as well as potentially results from the MRD as well. I think the first point was just to see what does the first year look like in terms of outcomes for patients. So thank you.